So, hi everyone. My name is Dr. Harshal Padekar. I'll be one of the co-hosts for today. So, I am a general surgeon by profession. I'm currently working as an assistant professor in Grant Medical College and Sir JJ Group of Hospitals, Mumbai. So, I welcome you all today to UMANG. UMANG is one of the initiatives taken by doctors like you and me. We came together about 2.5 years ago and decided that we take an initiative where we go beyond the teachings of the colleges and textbooks, and we take a step further and get all the doctors from India and all around the world, if possible, and give insights about private practice, your soft skills, and getting better in your clinical practice somehow and get better day by day. So today, along with me, there will be Dr. Amit. He is again MD physician who's done his MRCP, and he'll be joining me today in co-hosting this panel. We have great people today with us, and one of them is again one of the dearest of all the medical students all over the India and now all over the world too, because he's getting his hands into teaching kids about MRCS and entrance exams too. So we have Dr. Rohan Khandelwal. Hello, sir. Welcome to Umang. So, as we all know, Dr. Rohan Khandelwal, sir, is a general surgeon by profession. He's done his MRCS from UK, and he has done his fellowship in breast oncology, and he's currently working at CK Birla Hospital, Gurgaon. Yes. Hi, sir. Welcome to Umang.
Thank you very much, Harshal. Thank you for this opportunity, and I think it's a great topic which you people have chosen, and we're going to have a great discussion.
Yes. Amit, to you now. Could you please go ahead and
Thank you, Parshal. I think I should begin by saying, "Bade hi umang ke saath." I have the pleasure of being here. It's the first time on this platform, Gauri. Thank you so much. I think the first loud applause to Gauri and her entire team for keeping the Umang flag flying high. She posted on the group a little while back that it's the 29th episode, Gauri. Correct me if I'm wrong, on the Zoom of Umang, and I hope, as she said a few minutes prior, it becomes pan-India and soon a global activity in her vision. As Harshal has rightly said, we are here discussing an extremely important topic. But prior to that, an extremely important announcement. Please keep yourself mute. I think the old adage, speak when you are spoken to, applies a lot to Zoom. So let's keep it that way here on this platform tonight, because we have an important topic. We have a galaxy of speakers. And if we want in between, it will just interrupt train of thought. We have a chat box at the bottom. Please type in your questions. At the end, we could select them, and then we could ask the panelists, the speakers on your behalf. Having said that, I have the privilege to introduce Dr. S.K. Mathur, and I have the pleasure to introduce my close friend, Dr. Ashish Fadnis. Dr. S.K. Mathur, the privilege is obvious, a very, very senior faculty in himself, a professor of surgery at the KEM Hospital, a past head of Department of Surgery at the Nair Hospital. Presently, sir is the president of ZTCC in Mumbai and also the task force member for organ transplantation. We welcome you, sir, to give your valuable insights on tonight's important topic of overseas education, the value of the Indian clinical practice. Thank you so much for joining us, sir. And as I mentioned, the pleasure to introduce my close friend, Dr. Ashish Fadnis, phenomenal surgeon, a great human being, a wonderful storyteller. I mean, I could tell you a lot about his orthopedic skills and his knee transplant finesse, but then he can I'm not saying spinning a yarn. That will give it a different context altogether. But Ashish has a phenomenal vocabulary. It's a pleasure to have you, my friend. And I think we welcome them both. Over back to Harshal.
Hi. So we understand that today we want to discuss that topic, that whether the overseas education is actually helping people get a clinical acumen and do better practice in India. So we would want to start with Dr. Rohal Khandelwal sir first. If you could just tell us exactly how is this overseas education, how does it work, and does it actually differ between the UG education and the PG education, and how does it help people after coming back to India? Does it change the scope of medical practice in India?
So if I can take a few minutes, I was never preparing for the Indian PG exam. I was always preparing for USMLE. But due to certain circumstances, because I was the first batch, there were some university issues. My degree was not released on time. During that period, I cracked the Indian PG exam as well. And by chance, I got a surgery here, and I decided to continue it in Safdarjung. At the same time, once I had finished my MS here, I went for fellowship in US, and I done my MRCS, so spent some time in a breast unit in UK as well, and then finally came back and established my practice here. So once I'd done my MS and my first fellowship in India, my intent of going outside was very clear. My intent of going outside was to enhance my skill set, but more importantly, to learn, soft skills, to learn time management, and to learn good work-life balance from those people. And I think so. Those are key. Things which I learned and I've implemented in my practice. And over the course of the discussion, we'll discuss those further. I personally feel that every Indian medico should be exposed to overseas education, even if it's for a short duration, because it's a real eye opener for us in many regards. And it does benefit us directly or indirectly in our clinical practice.
And Ashish sir has himself been to UK. He's also done his MRCS in orthopedics. So Ashish sir, what do you think? How was your experience regarding this whole entry into PLAB and then doing via MRCS and the training course that you underwent over there?
Right. So, to just make a small correction, it's a MRCS in general surgery, because orthopedics is a specialty over there, and it's a FRCS trauma and orth, which you'll get at the end of your training over there. Now, as Dr. Rohan mentioned, that he was actually aiming to start doing his post graduation abroad. That is where he started. I was fortunate enough to have a post graduation, and I attended a few these orientation programs just after the MBBS, where it was made very clear to me by the people who are giving them is, was secure your place at home first. Ultimately this is your home. So if someone is getting a post graduation in India, I would definitely say, okay, get your post graduation here, uh, know what you want to do in life, and then, as Dr. Rohan said, that he went to we passed out in maybe 99 2002. That was the era when a lot of things were new. For example, joint replacements, they were being done, but they were few and far in between. Even our bosses had been abroad on short courses, and then they were sort of getting over their learning curve in India. So for me, as a youngster who wanted to get over the learning curve, there was no way to do it in India but to go abroad to learn that skill set. So doing a post graduation here, you are sort of, I can say that you know what you don't know. And when you are going over there, you are going, let's say you are unconsciously unskilled when you begin your post graduation, because you don't know what you don't know. At the end of the post graduation, you are sort of consciously unskilled. You know what you don't know. And then at the end of the, let's say your training, whether you choose to do it in India or abroad, in my case, it was abroad. I sort of wanted to know that, okay, joint replacement, arthroscopy, or sports medicine, it's in its infancy in the country. It is quite well established, well researched. There is a way to bypass the learning curve, or not bypass the learning curve, but to go through the learning curve over there, so that when I start off as a consultant back in my country, I'm in a on a strong footing. Having said that, why UK over any of the countries? Because at that point in time, language was not a barrier. That was one. Going to the UK, the path was pretty well set. That you give PLAB, you have an endpoint, you apply for jobs, and you get into a job, and then you sort of work your way through the system. It has helped me immensely as a person, as a surgeon, and which, I mean, I'm sure you're going to ask us the relevant questions, and a whole new system of instruction and learning. Self-analysis, self-criticism, making and sort of keeping logbooks, keeping a record, and more so, sort of being shoulder to shoulder with the people whom you have read about. who have published, who have written chapters, and sort of knowing them, that they are, what is their thought process and how we can aspire to be them one day,
True.
and coming back home and sort of trying to set up similar practices in our own country.
Okay.
think,
That's right.
Ashish, you're in a very good nutshell. I think you've put it together. I just wanted to take it a little bit further with the permission of Harshal with Ashish here.
Yes, yes.
You said you like Rohan and Ashish, both of you did your postgraduations here, and then you sort of jumped and you went. There are a lot of postgraduates attending this session and young consultant as well. But if it's all so great, then why not rush off at MBBS level?
Yes. So can I take that, Ron?
Absolutely. Absolutely.
Yes. So here you have to understand. So there is a sort of rift between a homegrown doctor and someone who. So if there is someone who's a postgraduate who says that I want to go to England and immediately I want to start doing these high-end surgeries, I want to straight away do transplant. No, it is not going to be possible, because at MBBS level itself, their training is completely different, or a lot different to what the way we are trained. What you also have to understand is those systems are geared for their population, so they want an end product which will be in sync with their culture, their ethos, the way of thinking. The government is spending on medical education to sort of produce doctors who will serve their community and their people. They are not training doctors to go back to different countries and waste their money on. So if you are doing an MBBS, you are learning a whole new way of dealing with sort of patient management, approach to the patient. And if you are planning to come back, then there is a big issue about getting the exams, getting your NMC registration or MCR registration, and whether those degrees are valid. Having said that, the whole idea, and I think we are all moving towards the era of specialization, and even general, no one would come back doing an MBBS to India to do general practice. They would want to be specialist. And as you know, that in the UK, even the general practitioner is a sort of a program, like a specialty program. They have to undergo a training. So yes, to go at an MBBS level, that's a good decision. I mean, if someone can afford to, someone can get into a good medical school and medical college, you can start very early and sort of end up over there. But then sort of, I'm not saying burning the bridges, but it is virtually you're closing the door on coming back to India.
Right. Quickly, Rohan, your input, please.
So I thought your question was, why don't they go post MBBS? Is that what you're trying to
Yes.
ask them?
Yes.
Yes.
No, post MBBS or to do MBBS. I thought that you asked about why don't you go to do MBBS there.
So no. Because see, I'll tell you where the question came from. You both explicitly said you both went after your masters, after your post graduation, so to speak, and then it was all great, and whatever you both described. My point was maybe Ashish before MBBS or maybe after MBBS. Why not at graduation level if the grass is that green on the other side?
So graduation level, we have, I'll quickly, Ashish has already addressed quite a bit of it, but I do know students who've now started going to UK for MBBS as well since the last 3 years. And there was a student who called me last week. His mother is a dermatologist, father is an ophthalmologist, both products of MAMC. He's got through MAMC NEET UG, and he's got through a Cambridge MBBS program as well. And he was confused whether to join the Cambridge program or to do MBBS in MAMC. Eventually, he's decided to do MBBS at MAMC because he aspires to come back and practice here with his parents. So like Ashish said, that if you're going there for MBBS, slim chance that you're going to come back and you'll practice here. You'll most likely then eventually end up staying there as well. Post MBBS, those who go there, again, the main question is once you come back, you are just a glorified MBBS doctor. On your registrations, you just have your MBBS degree. Although in today's corporate culture, the corporate hospitals will still welcome you. I personally have a slight issue with that. And that issue is that in corporate hospitals, some of us practice there. So the pressures which are there of corporate practice. And once you come back, you don't have a patient base. And the corporates expect you to deliver results immediately. Sometimes there is a mismatch there. And I've seen a lot of doctors who come back for a short duration, then they become frustrated and they eventually end up going back again to the country. So that is one issue. And I think so we can debate over it later on more specific scenarios. But that's the basic perspective. I mean, having said that, there are a lot of people who are going post MBBS and they're happy there. They're not coming back. I would say only 25 to 30% would want to come back. 70% are happy there. They don't want to come back. In fact, more than that, maybe.
Amit?
So I'll just quickly take a question on that. As Dr. Rohan also said the same thing, and Dr. Ashish also, they pointed at a very specific thing. They wanted a work-life balance. So that's one thing which they have pointed out, and that's one of the main reasons why people consider going outside. So if SK Mathur sir would quickly take on this point,
Yeah.
what are your thoughts, sir?
No, I will pick up from what the original question was. And I agree with both Rohan and Ashish to that extent that if you want to go at the MBBS level or even after MBBS and want to do post-graduation, that means you are going to settle in that country or the Western world. Let's put it there. You can go to UK and go to US. You can come from US to UK. So the atmospheres are almost same, though the US is more commercial than the UK because systems are different. But if you want to come back to India, then what you have to do, what Rohan and Ashish have done, that you finish your post-graduation here, you have got grooming here, and then you are going to enhance your skills in a particular field. Now, here one have to understand why there is a need for that. You look at the curriculum post-graduation, MBBS level, there is not much difference. 5 years here and 5 years there. Okay. But at the post-graduation level, it is always 6 years, 5 to 6 years, right? While we have 3 years. Okay. Now, at 3 years, you want to become a consultant. And as I think Gauri said that when she went to practice, she found it that she's too raw to get into the practice because there are a lot of things which are not known. And that's why our system doesn't allow that. And that's why you have to go abroad. Now, in the country, there are, like Memsi Rohan mentioned, I'm the one who did my senior residency there, post-MS, because I'm a MS from Gwalior Medical College. Okay. So 3 years for MS and then 3 years for the post-graduation. Because in Delhi, in the central government services, you can't become a specialist or a lecturer unless you have 3 years post-MS, post-graduation. Okay. That's where, in some of the areas, like Mumbai, it is you become a lecturer after MS. Okay. So those 3 years of lectureship are actually equivalent to what you are getting training abroad and next 3 years, or what you will get in some of the institution in India, like AIMS or MMC in the central government institution, that is 3 years residency. That is the time then become mature enough to then become a consultant. Okay. So there's a basic difference in the training where we are lacking. And that's why we have to go then abroad for, yes, if certain skills are not available here at that time, like Ashish mentioned about the knee joint replacement and all that. But today, if you have done the orthopedic surgery here and you work for 3 years in the department, I think you will be as good as this joint replacement surgeon as anybody trained abroad. I don't think there will be much difference. So that's one we have to understand that our training itself is inadequate, okay, in numbers of years, particularly in majority of the states. So that is one important aspect of what we are talking about, and that's what the people should understand. Now, second thing, Ron touched on the corporate practice. If you go and work there for 6 years or 7 years or become a consultant, actually you become misfit to practice in India. Truly speaking, you have to come down in all your from high pedestal. Okay, and that is if you want to get into a teaching job in a university level, there's no lateral entry here. You have to start as a like one person who is done MS fresh, and you will be entering at the same level, and you will be going through the same hierarchy where the two people higher in the unit will control you. Even if you know they are better than them, you are better than them, then there will be jealousy. So you will be suppressed. Okay. But I'm not saying that everywhere, every time it happens, but it does happen. Okay. So you get frustrated and you come out. You go in the corporate sector, you go in the private practice, you know that you have to compromise on everything. Okay. Including how to get the patients. So one has to, that's why if you are going for training, coming back, and because you are used to this system, you work it, that's fine. But if you're going for at the MBBS level or post MBBS immediately, then think of settling down there, don't come back.
I think very clear words from Mathur sir that if you're going at a graduation level, good to settle down, find a way through the system and then work there. And if you're going after to hone your skills, then obviously important to come back. I think Harshal, you will agree with me. What the speakers are trying to head towards are two areas. One is the clinical aspect of the practice, and one is the non-clinical, wherein maybe the work-life balance, the finance, the etiquette mannerism. That is where it is heading, maybe into. Over to you, Harshal.
Yeah. So there's one specific point that SK Mathur sir touched upon is training and skills that you get. But now, since we are in a phase of globalization and we have top-notch medical facilities here in India as well, we have good HPV centers, we have good amount of workload. So where does this point actually stand at? Is it that we are actually lacking in the skills and training part, or is it just a gimmick? Because we have seen that there is a sort of partiality seen in corporate setup. Since we are on this topic, there is a partiality seen in corporate sector wherein few people think that there is a preference for a foreign degree just for the sake of it, just because it is a foreign degree. Few people have this misconception. So if Rohan sir and Ashish sir could take quickly this point and give us an insight about this. Ashish sir first, can you please give
Yeah,
us?
so I would like to dispel this myth that the corporates have a predilection for foreign degrees.
Mhm.
Ultimately, you have to understand that they are going to run a hospital and they need their beds full. Whoever
Right.
is going to give that, whether it's a doctor who has got a very big patient following and a patient base where
Mhm.
he is going to practice in a particular area, they will be more than happy to welcome that person.
Correct.
Yes, a person who's trained with a foreign degree comes with a different set of sort of professionalism, or he brings some amount of research, audit. You have got JCI, NABH, all these accreditations taking place. So some of these people are welcome. But to dispel the myth, no, actually, corporates they work purely on sort of economics. To get the first job, as a person, let's say Ashish Fadnis, who has trained only in India, and Ashish Fadnis, who has done an MRCS, there probably Ashish Fadnis have done an MRCS, stood a slightly better chance of getting into a place in the first place, at least to open the doors and get a foot in the door.
Right.
If I would have got into an established hospital, but to answer the question, yes, it actually depends more on economics. I don't think it matters too much.
Okay. And what about the skills and training part, sir? Do you think that now, since we are having good facilities, we have robots at many centers, do you think that it is actually different? You think it is still the same thing which was there in 1999?
No, so the difference in technology and techniques between the Western world and India probably has changed. It is much shorter. So something, let's say a treatment modality is launched abroad, within no time it comes to India. But it is done by the consultants who are higher up in the hierarchy. For a person to actually train his hands on, let's say, a Da Vinci robot or a robot, he has to work his way through the system. And I agree with Dr. Mathur that our 3 years of post MS does not make you gives you a degree, but does not make you consultant ready. So for that, you need to invest more number of years. We are doing a lot of joint replacements, but the number of postgraduate seats have increased. So how much of, but at the same time, the infrastructure regarding the availability of operation theater tables, chances, the number of surgical days, they have not proportionately increased. So though we are having more throughput of postgraduate students, we realize that they are not as sort of surgically well exposed as we would have liked them to be.
Okay. Point taken. What about same questions to you, Rohan sir? You think the training and the skill set has a difference in between both of these?
So let me answer the second question first because Dr. Ashish just finished that. So I agree that the gap in technology and skill sets between the Western world and Indian world are reducing. But one major gap in India which still exists is the gap between the government hospital and the corporate hospital. The skill set, the training there. Right. So even though in the corporate setup we might be having robots in a lot of hospitals, but only a handful of AIMS have a robot in the government setup, right? So the training, if you talk about surgical training per se, even in the top institutes in our country, government institutes, it is still very much similar to what it was when we were training 15 years back. So not much has changed, which is why you can even see that why less number of students are now preferring surgical branches. And I'm sure everyone saw that WhatsApp forward that this year that only 4 people chose surgical branches in the top 100. Majority were choosing medical branches, and everyone wanted me to express my views regarding that. I was refraining from doing that. But I think so. Let me mention one big reason for that, why that is happening is that there are a lot of, interventions and procedures which are happening in medical branches now as well. So the gap between a surgeon and a medical doctor in terms of interventions is fast reducing. And the advantage for them is that their first 3 years, they don't have to slog around like a surgical resident does. They are just reading their books. They're not doing 36-hour duties like us. And they are just learning the skill set and their interventions in their DM course post 3 years. Whereas for us, it's a struggle to get surgeries right from starting. Once you finish your 3 years of surgery, it's a struggle either to get into senior residency, or if you land up in the corporate setup, you are totally in an alien world. You don't have the soft skills to talk to people, which are not taught in government colleges when you land up in a corporate hospital. And B, the skill set required to survive in the corporate world is totally different. So you need to spend more time, as Mathur sir said, you need another 2-3 years to adapt to that kind of a setup and understand that skill set. So that is point number, the second question. The first question, um, can you remind me, Harshal? I'm sorry, I forgot the
Yeah,
first.
so
Corporate
the
hospitals,
skill.
do they give a preference? Corporate hospitals, do they give a preference to?
Correct. So as Dr. Ashish said that the initial breakthrough, yes, but after that, it's just a game of how many referrals you're getting, how many patients you're bringing on board. When somebody asks me, should I do an MRCS? My answer is very clear. If you want to go to the UK, you should definitely do it. That's the best way to enter the system there. If you want to go to Middle East, yes, your pay scale is 2.5 to 3 times as compared to a plain MS or a DNB. If you want to stay back in India, not go there for a fellowship or advanced training also, it will just give you the initial break, nothing more than that.
I think,
So,
can I just jump in, Harshal? Yeah.
Yeah.
The skill set, I agree with both Rohan and Ashish. I think you've been making that point, and I agree that the skill set, even Mathur sir agreed that somewhere maybe it's a little better after you achieved a post graduation. I want to hear from the both of you. You touched upon it briefly. The little of finesse. See, when patient looks upon a doctor is a wholesome package. The way he talks, the way he dresses, the way he the aptitude of a doctor, the attitude of a doctor, the empathy the doctor shows. So, as Rohan rightly said, that when we were in our own government municipal setups back home trying to learn medicine or surgery here, and when we went abroad, did the polishing, was there a little better? Have we come back as a little more finessed version of what we left? And is that also one of the reasons why the overseas training is essential? Any
100%.
comments on that?
100%. And I think so. That is one of the reasons why somebody should be exposed to an international setup, even if it is for a couple of months, to get that polishing done. And, this is a point which I've been constantly raising on Twitter as well, that NMC is bringing about so many changes. But there are two courses which should be introduced in the MBBS curriculum. One is a soft skills course, and the other one is financial literacy for doctors. Those are two courses which should be definitely introduced, touched upon, even for a brief period, would make a huge impact in the kind of doctors which we are producing and the way they interact with the patients once they come out in private practice.
Ashish, your quick comments before we, I think,
Yeah.
take Mathu's turn,
So,
because I think he raised a finger.
yes, so basically, the soft skills course is being introduced in the MBBS itself. So they have got an early clinical exposure and a soft skill. It's called, there is a mnemonic and it's called something. So yeah, to take the point, the government has sort of introduced certain changes in our MBBS as well. That is it.
No, I know that clinical training now from first year itself, they're exposed to clinics. But I have been talking to, so I interact with students from first year till final year, but the soft skills thing has not been introduced as yet. I just hope it does get introduced because it does make a huge difference. Okay, somebody is highlighted. It's called ATCOM.
ATCOM, yeah, that's the word, ATCOM.
Perfect. I mean, a great. If this has come about, I think so. It's a great change, a welcome change.
So I think at this point, let's hear, because Mathur sir is the one who spanned it all, from the time of over generations prior, having done medical here at a time where maybe soft skills were not that important compared to clinical skills, and today sir himself being at the other end. So sir, your comments upon this soft skills part on being a doctor.
Yeah, see, the thing is that I'll touch upon 2-3 things, because every time they recurrent word the government medical colleges, okay, and where we stand. Having spent almost, I think, first 40 years in the government sector, okay, and then next 25 years in the private sector, I've got a good feeling of both, okay. Now, first thing is that, see, when we talk about the government sector of my time and the government sector today, there is a difference in terms of skills, okay. When my teachers, or when I was a teacher, the type of surgeries which were being done in the medical colleges were not available in the private sector. Let me put this very clear. I will give you a few examples, like the portal appendage surgery in KM hospital, liver resections and ripples were not being done in the private sector at all, be it Bombay Hospital, be it Jaslok Hospital, or any other in the hospital. Okay. It is only in Tata also. It started after some workshops were held in 1997 or 98. Okay. So it's not that. So that time, you look at the AIMS at that time. Okay, the type of surgical skills which were available in the government sector was much higher than the private sector. Private sector was doing hernia, hydrocele, gallbladders. Gallbladder used to be considered as a big major surgery. Today it is like a hernia hydrocele surgery. Okay, though it should not be treated that way, because there are a lot of bile duct injuries. So thing is, now things have changed because the private sector is flooded with the technology and flooded with the people who have got a better skills. Now, where the medical colleges have lagged behind. So you look at this way, you are using the word robot. Okay. Now, I remember that when I'm teaching the students, I use that word, and some of my students remember that it was more of a derogatory word when you use the robot. That means you don't have a thinking power. You work like a robot. Okay. Second thing is that as you grow senior, do you want to become antique piece or antique person? And what is the difference? An antique piece, yes, it is valuable, but it is a stationary thing. Okay. An antique person can be two types. One who will not grow in their knowledge, in their skills, remain there where they are. And there is a group who will grow with as the technology is advancing, as the new things are coming, they will learn and keep abreast with the knowledge and the technology. So unfortunately, in the medical college, what has happened, that inertia had come. And the inertia, we are overworked. Why to learn? See, I will tell you, laparoscopy, it came in 1990 during my time. Most of the senior people started criticizing it. Oh, it is a useless thing. People started devising that we'll do mini laparotomy and then do it. the people started measuring and publishing 2-inch incision. I have removed the gallbladder. What is the big deal in doing the laparoscopy? Okay, till the acceptance come. But because the people were not accepting in the medical colleges, they lagged behind the skills. They didn't learn the skills. And because they didn't learn it, they didn't pass it on to their students. And that's why all the minimal access surgery, today, it is concentrated in the private sector than in the medical college. Even today, if you go to the medical college, yes, gallbladder they are doing, they may do appendix, but you ask them, are you doing minimally invasive colectomies, esophagectomies, gastrectomies, or more advanced liver sections and the pancreatectomy? No, they will not be. So it is a question of how they are advancing and not advancing. So it is own doing. It's not somebody has responsible for it. Private sector, you have no choice because you have to compete with your colleagues who are as skilled. So you have to get those skills. There's no choice there. So that's where we criticize the medical college. Yes, they should be criticized if they are not advancing. But it is a sad affair. It is also sad affair because the government is neglecting it. See, one of the reasons why AIMS maintained that time prime and today also to a great extent, because at that time, none of the MPs, ministers, or IAS officer, IPS officer were reimbursed their bills in the private sector. The first time it came when the Apollo Delhi got created, and that is the time they passed this bill that the IAS, IPS officer, ministers, and MLAs and MPs can get their treatment in the private sector. Otherwise, they were compulsorily used to go to the government sector. And because they were going to the government sector, automatically things were happening to accommodate them.
Can I politely get you back to the soft skill set?
Yeah.
That was the point under contention, that going abroad and training yourself, does that make you a little better in your soft skill set, as both Rohan and Ashish felt? And what's your experience about that?
Yeah, so see, the thing is that, I went for abroad, but not for basic study. I was already professor when I went, but I went to acquire the skills in the liver transplant. Okay, so when you are, it depends on what stage you are going. If you are going after MBBS, you are going there to acquire the basic skills to advanced skills. If you are going after MS, you are going with a goal to get some extra training in some particular specialty. Okay. If you are faculty, then you are going with the idea that I want to do these surgeries. I want to better my skills in that particular field, then you go there. So it goal changes according to at what level you are trying to go. Okay. Now coming to there are now training is available in India. Like if you say living donor liver transplant, the training in India is far better than in the Western world, because living donor transplant is not done as often in Western world as in India. Robotic surgeries in India, in some of the institutions, though it is in the private sector, you said it is a consultant done, but they are doing it. Basic robotic surgery, yes, in US it is available even in the district places.
So we are catching up with the Western world in these aspects as far as the training and the skills part is considered. But we should agree to this point that India is not emphasizing on the soft skills part as of now. That is something which is lacking. I think that we can conclude from this discussion of ours. And just to come to the basics once again, there are a few confusions regarding whether people should take up US for the further studies or UK for the further studies. Let's come to the training modules and the entrance exams which come if you consider UK for the matter. So the basic entrance exams are same for all the entrance exams. So it is MCQ based. UK has the same way to go about it. US has one of their exams staged the same way. But there is a certain part of this exam where it is staged for the soft skills part. So they do emphasize on this. So for the audience, quickly, if Rohan sir can take this question, how is the structure based for exams and the training when you go from, suppose we consider that we are planning on going after the MBBS part. So how does it go? And if you could take on MRCS or MRCP or USMLE for that matter. So how is the training scheduled and how is the entrance exam scheduled?
So the two big countries where students go after MBBS are US and UK. And Australia, there are less number of seats there, so we can talk about Australia later. USMLE, the exam has also undergone a lot of change. When I appeared, it was a step 1, step 2, CS, and step 3. Post-COVID, the clinical skills exam was dissolved, and they will reintroduce it in the future. There's no clarity on that right now. It is step 1, step 2, CK, and step 3 are all MCQ based exams. But in step 1 now, earlier they had a 3-digit score and a percentile. Now they've done away with that. It's just pass and fail now. So that was filter number 1 for foreign graduates, and usually foreign graduates used to fare well there, and that was one of the filters which used to allow them to get a adequate number of interviews. But now they've done away with that filter. So now your filter is step 2 CK, where the marks come in or the percentile comes in, and your step 3, which gives you an added advantage in terms of the visa you're applying for, a J1 or an H1B. The usual time duration which you require is a year to year and a half to clear the exams. And a lot of students, because they've done away with the 3-digit score, are now appearing for the step 1 exam in 3rd year or 4th year of your MBBS, which now is fine because you don't have a score attached to it. Other than that, you also need to have a strong resume, whether you're applying for US or UK, which is another thing which students now are realizing. And it's a welcome change that more medical student conferences are happening. They are actively taking part in research. They're publishing papers as well. So building a strong resume is also very important if you want to go abroad. That is regarding USMLE. USMLE is good for medicine, family medicine, pediatrics. Surgical branches are challenging to get, not impossible. You again need to have US clinical experience and a strong resume, and you should be willing to put in 1 year of a preliminary training there, and then you can get a surgical branch as well. I know people who put in 2 or 3 years, done research there, and I've got into dermatology, radiology as well, orthopedics, which are even more challenging branches. UK on the other hand, you have PLAB, which you appear for, and then you work your way up. You choose a pathway there, and then you gradually work your way up that pathway. Now PLAB is also going to be changed to something known as UKMLE. So it is going to be on the same lines as USMLE, again MCQ based exams which are going to be there. Both in America and in UK now, you also need to clear your basic English language exam to be eligible for these places.
Right. Okay, so I think that answers the part wherein you mean to say that the medicine and allied branches are better off in US. If you want to go, then USMLE is the way to go. And
Easier
UK, yeah, easier to go. And UK does not have any such bias if they want to go for medicine, right? So suppose we've done with the entrance exam part, and after that, how is it different, the training module? Like Mathur sir had told us that it is 3 years, and then you go 3 years of your senior residency, then you are somewhat confident to become a senior consultant or something like that. So Ashish sir, could you please tell us what is the exact difference? How is the training module over there in PG graduation studies? How is it different from what it is there in India right now?
Right. So, so I can see that most of the participants here are at the residency or a post-residency level.
Yeah.
So, what you have to understand is, as we spoke at the beginning, why are you going there? Are you going there with an intention to settle, or are you going to come with the intention of coming back? And if there is some certain skill set within your specialty that you are looking for, okay, let's say someone doesn't know that. So, UK system is a very clear system. There are two pathways. One, so you have to understand that the government wants workforce, let's say, let me put it very crudely, they want us Indians to go and work over there for their patients and run the national health service. And training also happens, by the way. Okay, so there are two pathways. One is a career consultant grade pathway, and one in which you don't end up as a consultant, but you keep on doing the work for the NHS. But in the meanwhile, also sort of, get a little bit of training. When I say a little bit of training, there are certain one pathway, let's say pathway one, where you end up as a consultant. The government and the trainer is sort of, the onus is on them to ensure that you are completely trained. So there is a structured training program. And then there are certain other pathways where you are more like a service grade. So you'll be doing on calls, you'll be doing, let's say, staff grade jobs. You'll be doing joint replacements, complex hernia surgeries, complex colorectal surgeries, but you will not end up as a consultant. Here, you'll be more as a service provider. So they'll acknowledge the fact that, okay, you're trained in JJ, you're trained in MAMC, you have a certain basic skill set. I can trust you with these surgeries. Let me hone your skills slightly, and then I can utilize you to get rid of my waiting list to sort of treat my patients and not have the onus of, responsibility of settling you down in some particular town or city. So in this particular part, if a student is very clear, like Dr. Mathur, he went for a particular set. He wanted to learn liver transplants. He could do basic surgeries very well, and he was very focused that he wanted to do liver transplants. So let's say there's a lecturer in one of the government colleges who said that, okay, I know most of the things. I want to do only minimally invasive spine surgery. I'll go to Cardiff, or I'll try to go to this and this place. So appear for PLAB, MRCS, and then try to look for jobs which are there in spine surgery or which have a rotation in spine surgery. On the other hand, there are these paid MCH courses right now, which they, or the MTIS scheme, which is the Medical Training Initiative Scheme. And interviews for medical training initiative schemes happen quite often in different parts of the country. And there are different deaneries, or deaneries means there are certain teaching hospitals which have got smaller hospital, which are called as district general hospitals attached to them. So they need a workforce, but at the same time they said that we cannot attract the workforce unless we train them or promise them something in return. So they come as a medical training initiative scheme where you rotate through different consultants, you rotate with different specialities, but at the end of the 2 years there is a sort of unsaid rule, or there is a said rule that you need to go back to India, because that is when your visa will finish. The beauty of the UK system is that whichever career path you're going through, you are paid well for it. So for a basic doctor in whichever specialty, you would be able to sort of rent out a good house, your children will go in a good school, you'll have a good car, basic necessities of life at that particular stage will be, and you'll be able to save a little bit. Now, when you enter a career consultant grade, which is a more sought after, it is very competitive. And here you're competing with the local homegrown doctors. So there is no bias regarding, okay, he's a brown and he's a white. No, aisa bias nahi hai. The bias is homegrown versus foreign doctors. So homegrown doctors are people who have done their MBBS over there. So my suggestion to you will be, like, take it like a game. A game has its rules and they have laid down the rules. So we have to play the game by their rules. If they want research, our CV has to show research. If they want you to have done a vascular surgery, sort of orthopedic surgery, emergency surgery job, then you need to show that on your CV and then proceed. And once you enter the system, the onus is on the National Health Service to train you. So there will be a competency-based assessment. They would have laid down that, when I am looking at a consultant general surgeon or a colorectal surgeon, he should have done so and so sort of whatever rectal surgeries, so many of them. At the end of every job, there is an assessment. This assessment is done by the trainer and is done by the trainee. So and it is both done anonymously. The trainer will say, "Oh, this is a brilliant chap. He's got a good prospect, and I strongly suggest that he gets trained further." Or he said, "Okay, this is a good chap, but he requires training in such and such things." And they also have a 360-degree assessment where the nurses on the ward boys on the ward, they also assess you. And they said, okay, this fellow is very good, but he's extremely rude. He doesn't have good manners. Or let's say he has good manners, but there is an interpersonal issue with him. So the person at the top in the deanery, who is the main sort of in charge of the training program, he sort of takes notices and he tries to fill in the gap. He said, okay, you did your bit with colorectal surgery, but you need some exposure in, let's say, laparoscopic surgery. You go to this particular place next. On the other hand, the trainee gives an anonymous feedback to the deanery, and he says that, this 6 months was a waste of my time because this consultant did all the surgeries himself, and all I was left to was closures, and I couldn't do. So the deanery would now stop sending fellows to that person. So what that would mean is that the local hospital has to spend on a person to employ. So they lose out on money. So therefore, there is a check on both the trainer and the trainee. There is a onus on the trainer to ensure that the end product is good. So there are these two career pathways, and depending on where you are in the stage of your career, let's say someone is going post MBBS, as Dr. Amit mentioned, you are looking for a type 1 program, which is where you want to end up as a consultant. And now it has all changed to the specialist trainee program, ST3. So you run from, so again, to enter, someone asked the question in the chat box that what it is to be an ST3. So ST stands for specialist trainee, and it goes from 1 to 6, where 1 and 2 years, first 2 years are the foundation. Like if you want to do general surgery, they would want you to rotate between accident emergency, vascular surgery, a little bit of orthopedics, a little bit of general surgery, and then settle down on one specialty, like let's say, for example, urology or a colorectal surgery. On the other hand, if you are aiming that if you have done all these jobs in India, you're saying that, okay, you have worked in, let's say, AIMS or MAMC or any other college, and I've done these basic jobs, I want to enter in an ST3 program, then you straight away are in competition with the local graduates. Then your CV has to stand up to scrutiny against them. And once you enter an ST3 program, this ST3 program runs from ST3 to ST6. And after, I think after ST4 or so, you are able to give the exit exam, which is either the FRCS general surgery or FRCS specialty surgery or the FRCS trauma and orthopedics.
Right.
What the delegates are listening also have to understand, that there is no relation between you getting an FRCS and being ensured of a job. That is one. There is no so that exam, the degree, the certificate of completion of training, everything is dissociated. So at every stage, it is not amalgam. Like MS karne ke baad, you just hire a MS. It doesn't assure you of a job in Lilavati Hospital. So something similar to that. So you can only get an FRCS general surgery, but you're not assured of a job in the UK.
I think fair point. Very well taken, Harshal. I think last we covered a bit of the clinical and coming back. We've also a little of the clinical skill set and training aspect. Take a bit and the perspective discussion with globalization and with the global right in the rest of the world. Yes.
Your voice is not clear. We can't.
There's some glitch in your network. Yes.
Is it better?
No.
The screen has got a line coming, so there is some disturbance, electronic disturbance.
Can speak now, Amit?
Can go off video, Amit. Go off video and speak.
Yeah, go off video for a while. Yeah.
Okay. Is it better?
No.
Just try and speak a bit.
Yeah, Harshal, you could take it forward. I'll join back in a minute.
I think we can hear you fine now. Yeah. You can take over your question, or else I can take over. Fine.
Yeah, Harshal, take over.
Okay, fine. What we had, one point specifically said by Mathu sir also, and Ashish sir also pointed out that point. There is a problem with the whole hierarchy system in India, and the part where the student gives the feedback for the teacher, and the teacher also gives a feedback. In India, we see that there is a feedback continuously and constantly given by the teacher for the student, but there is no part wherein the student gives a feedback for the teacher. So that point is somewhere lacking in Indian system. And do you think, I would like SK Mathur sir to take this point specifically, because there is somewhat of a problem. I think you agreed to the point that we are overburdened. We have too much of cases pending. And at the same time, despite having a lot of caseload, we don't see our junior consultants or junior residents getting that benefit from those caseloads. So you did point out there was a problem with the hierarchy system, wherein the senior gets the rich get on becoming richer and richer, and the poor still stay poor. So if Mathur sir could take on this point.
Yeah. So coming to the this feedback system, see, yes, it is a big deficiency in our system. As a matter of fact, AEM, both for undergraduate and postgraduate students, at the end of their undergraduate posting, I had a feedback form designed on 10 points in which the students will give their opinion and they were not supposed to put their names so that it cannot be held against them. And every member of the unit, because house surgeon is also supposed to teach, registrar is also supposed to teach, lecturer is also supposed to teach, assistant professor is also supposed to teach, I am supposed to teach. So all of us were evaluated by each of them on 10 parameters, like punctuality for taking the clinics, contents of the clinics, how they explained everything, did they answer their questions or not, and all that thing were there. And it used to be very, very informative for me because it helped me in knowing who are the people, not for punishment, but where are their deficiency. See, everybody is not born as a teacher. Okay, people have to acquire. I was not born as a teacher. We acquire the skills as we grow. Okay, so that is the advantage of having a feedback system. Yes, US, UK, it can be used for punishing either side. As we mentioned that if there is a bad report against the trainer will not get the residence. Okay, or sometimes they will be shown the door from that hospital itself. They may have to look for another job, which are extreme things. But there has to be midway that there should be a feedback system which we should be anonymized and it should be available because that is to improve the people, not to punish the people. So, and that is the thing. Now, yes, hierarchical system, see, it all depends on our mindset. I look at this way, if I'm a competent person, okay, I'm not scared of competition from my juniors. So that means I can train them and I'm confident of that, yes, if they are trained even better than me, it's not going to affect me. And I will like to tell you a story here in KM days because I think those of my students who are there, they will recall that I was stickler for training. Means for house surgeon, first I had to see, I will assist, I'll make him do under my supervision, not by lecturer, registrar or the house surgeon to house surgeon. That was same way hernia and everything surgery used to go. And for the seniors, then again, training like this. So I trained my people when they finished the MS, they could do the shunt surgery also. Okay. Now, one of the very senior person, he met me in the corridor and he stopped me and he said, Dr. Mathur, it's fine to teach and do all these things, but you know that you are creating your competitors. And when you come in the private practice, they will be your competitor and you will regret. That's what the word he used. And I just told him, sir, I'm not interested in private practice. So I'm wedded to this full-time system. So I'm not going to practice. So I'm not worried about it. Yes, when I came in the practice, I didn't stop my training part. I started DNB surgery and I trained the people. So I'm happy if my students can do better than me. So that's the way it should be. You should not feel scared of your students that they can, if they start doing surgery better than you, then you will be lesser surgeon. No, those students will always be thankful to you.
True. So I think Mathur sir has always had this holy concept and that Devta figure in terms of residency teaching. So that is, I think, but we can consider Dr. Mathur as one of those outliers in the graph. But we have had experiences from the residency. I think that is one of the reasons why students are picking up post-graduation courses outside India, because there is as Ashish sir pressed upon it, there is a structured training module wherein you get to do certain number of surgeries, you get to have certain number of skills, and that's the main point which he pressed upon. So that is one point which is lacking in the Indian system as of now, apart from the soft skills part. I think we can all
One
agree
point I want to
that.
make, Arshal, if you allow me, is
Yes, sir,
that
sure.
abroad, yes, it's a very structured thing, all that good. But remember, the human beings are human beings. The skills of 10 people, 10 fingers cannot be the same size. Okay. So 10 centers will not be of the same level. There is also difference there also. So you may find that you may get better training in particular center, while you may not get as good training in another center, though the average is maintained.
Yeah.
But when it comes to excellence, it differs from institution to institution, as it differs here in this country.
I think So I think
glitch of
overall,
network.
what we have so far seen is, the skill set difference in both the scenarios, the soft skills as well, a bit of the other aspects of teaching and the way of the training program. My question, which I was wanting to ask a bit prior, was with globalization and the amount of global travel which is taking place, where do our panelists see the importance of a abroad experience and a broad qualification? So imagine if you're sitting in a setting of city of Mumbai, Ashish may be in Jupiter Hospital, Rohan may be in Delhi, and imagine there is a UK patient who's visiting that city at that point in time. You are yourself MRCS qualified, and then the patient walks into the hospital, and if she wants to pick and choose, for example, that she has a surgical issue and then I would want to go to an MRCS, don't you think that would work to an advantage there, or it doesn't really make a difference? What's your take on that, please?
Who's taking that?
Two MRCS
So I'll go first. So
I'm
yeah,
without
so in this view,
MRCS.
so in the view of globalization, I don't think it actually matters. I mean, I can put the same question to you. Let's say you go to UAE, you go to the Gulf, and you need to visit a hospital. There is an Egyptian doctor, Indian doctor. You're going to go to. You are going to take a local review as well, who is doing better. And ultimately, it would matter on how good the person is from whatever feedback you are going to get if it's a one-off. But yes, if you are going to do it on a regular basis, like a medical tourism, someone wants to indulge into that, then it's a completely different story. Yes, where the patients who are coming from East Africa or from some other countries, they're actually looking at your qualifications, publications, your presentations, and there, this degree probably will stand up.
Yes.
But vis-a-vis, you compare that to someone who's like the director of hepatobiliary transplant in Fortis Hospital versus someone who's done FRCS and has just come back a few years back, then definitely, the patient is going to look at more number of things than just a degree.
Right. Rohan, your take, please.
No, I would agree with what Ashish has said. I mean, such patients, we are getting some patients like that in breast surgery, but more on the cosmetic side. Primarily because the waiting times in NHS for those surgeries would be prolonged, and the charges here are less. So when those kind of patients come in, they do look at our profiles and they reach out to us and then they contact us, and they always prefer somebody who's been trained there. I mean, I'm probably not the right person to speak on this because the hospital which was started where I work was built on UK guidelines. It was started as a women's health center, and there was a nurse who would come in from the NHS to set up all the systems. So we do get a lot of patients who have international insurances. We do get a lot of patients from UK and other countries as well. But I don't think so. It's a major chunk of our patients. Majority of our patients are still Indian patients.
Okay.
And three things, I mean, if you just permit me, because three things which I would really like to touch upon, which I think so have been somehow got left out. So number one is that a lot of postgraduates and a lot of people who are listening to us are thinking that there are a lot of lacunae in India and everything is rosy abroad. So that's not the case, first of all. And let me highlight that to you, that problems happen there as well. But the difference is that once problems happen, they analyze them. There is a feedback mechanism. They work on them and they improve them. A classical example is the M&M meetings, the mortality and morbidity meetings, which happen there. In America and UK, they happen in a very constructive manner. Whereas when you start them in a corporate hospital in India, it eventually boils down to fights amongst consultants, and it's predominantly the juniors who are presenting, and then everyone is taking a dig at them. And I was in a bariatric surgery unit at Harvard. I've seen needles being left over the spleen. But because you have such strong surgical safety guidelines there, it was accounted for, it was retrieved, there was a proper meeting which happened regarding that, and systems were changed. I've seen clindamycin being given to a patient who had a red tag saying she's allergic. The breast flaps were raised like this. She coded for 7 days. She was in the ICU. Eventually, She came out of it, the surgery was done again. Again, there was a review which happened. That is where we are lacking. There are mistakes which happen, but people shy away from reviews. Reviews are not proper. So it takes time for things to improve. That's number one. Number two was one thing which I want everyone to understand is that we think that as Indians or Indian doctors, we are very hardworking. We are willing to put in long number of hours, and that would be a differentiator when we go there. Well, what those people are looking for are smart workers. And that is what we need to learn from them. In America, as an extern, things for me used to start at 4:30 a.m. when I was in this Harvard unit. The first year resident used to come at 5:15. 7 o'clock, the case used to be induced by the anesthetist, and the call used to go to the consultant that your patient is induced. But by 4:45, 5 p.m., everything used to get wrapped up. Everyone used to leave except for the person who's on call. And they used to ask us that, please go and enjoy. Please enjoy your weekend. Right? So that work-life balance, how they used to manage and finish their work in those 7 or 8 hours are the skills which we should learn rather than, just postponing things, which is a very Indian thing to do. And then to say to everyone, oh, we are overburdened with work. So those are some skill sets which everyone should learn from those people, how they manage their time, how they manage to enjoy as well, and work and do quality work as well.
I think very fair points. Very, very, very fair points indeed. Right. Harshal, you wanted to add on something? Any questions in the chat box, which almost crossed 10 o'clock?
Yeah, we are almost at the end of the session, and that was a very good point. We started from the work-life balance, and we have ended on the same point that yes, it is something which is there prevalent in outside India, and something which we should learn on. And rather than focusing on the lacunae which are there in our system, we should focus on what we can take from the other systems and integrate in our system and get further into the training modules. Ashish, you have something to say?
Yeah, so I was going to highlight a few things. What Dr. Mathur said to the juniors who are asking questions regarding MCH and everything. See, there are good doctors and bad doctors everywhere. But what the UK ensures is that there might not be any star players, but there will be mediocre doctors but safe doctors at all places. So the good things to imbibe from those systems are these audits, self-assessments, comparing our practices to a known standard, a blame-free environment. So let's say even if you are a registrar and your houseman comes and tells you something that he doesn't know, rather than having telling him off, it is you can start sooner by saying that, okay, you don't know certain things, I'll teach them to you, but next time just make sure that you have understood these things and then do, rather than shying away from saying I don't know extent that whole system. So that is a good thing to take from them, where we can start making these small changes in all these hospitals which are JCI accredited, NABH accredited. So these are systems which are there, which can easily be brought on in our government hospitals.
Correct. I think we have come to a point wherein we understand that the work-life balance is better. And I think Rohan sir also pressed upon the point that the payment as such, which that is one of the factors to consider about, that people go abroad, and it is not as such the main factor to be considering. If it is about the skills, training, and new things to acquire, that is definitely one thing you should go about for your further trainings abroad. And that's how it will affect your clinical training as such.
No. So one more point is, Harshal and everybody, is that the research atmosphere while doing the post-graduation, unfortunately, it's not encouraged. It's not, it depends on individuals. Okay. So some people will encourage their residents to do the audit-based research, which is simplest to do. You don't have to go to the molecular-based research. Even abroad, yes, some people do the molecular-based, but then they take the off from their residency, go for 1 year and do the only research job and come back, which our system don't allow. Even if you want to do, you can't do it. But audit-based clinical thing, all that can be very well done, and that thing should be encouraged, because there was, I think somebody mentioned about the dissertations. Okay. And Amit, Ashish, you mentioned about dissertation, I think, in your, or somebody mentioned in some of the things which you have put it in the group. So dissertation was basically in a way to encourage the students at that time.
Yeah.
Not today, you can get on Google everything, but
Yeah.
there was that you go to library, you take out the index medicus, look for the references, and then you search for the journal. When you open the journal, not only you will read that, you will read some few more articles. So it was just a way of actually encouraging to enlarge, improve your knowledge about the subject. And then write up. See, because when you are writing, your writing skill for the research goes up. Unfortunately, people use it in different way. They will copy it, ask somebody else, ghost writers and all those things. But that is that happens everywhere. But that is a dishonesty. That's not the aim for dissertations. Aim was different.
There was a question in the chat box regarding Korea and Japan. I think someone
Yes,
just
that's the
asked that.
question. Yes.
Surgical courses to attend in Korea and Japan as well. So I can say about orthopedics. Orthopedics, the South Koreans to a very large extent, and Singapore has opened big time to Indians. They have a long waiting list, and there is no entrance exam. You just need to apply, show interest in a particular specialty, and the referral pattern over there is very set. So therefore, you go to a center. It's a very, very high volume center. So in case you are at a stage in your career where you know what you want focused learning on only on that particular specialty, these may be very good countries to go. They love Indians. They love Indians because they don't know. They're not as good as writing in English as most of the Indians are. So they want someone to do their research. So it is sort of said with certainty that an orthopedic surgeon goes to Korea, he will come out with 3-4 publications, because the person over there has so much material that he wants someone to look it up, publish it, and move forward. So it is a good place to go, a good stepping stone, especially if you have done your MLEs or if you have done your PLABs, so you can enter that system. The other thing also, when I mentioned that treat every country as a game and you play the game by its rules, so you know where to pitch yourself at. If you want to start at an ST3 program and want to go on a type 1 program, they don't want you to be overtrained. So they would in the job description they would have mentioned it very clearly whether they are looking for a person to do independent surgeries or they were looking for someone to train. If they're looking for someone to train and you tell them already that you have done so many Whipple surgeries and so many cancer surgeries, then they would say, okay, this fellow is untrainable because he's already trained. So it's very difficult for someone to unlearn and relearn. So know which country you are going to go, know what is the requirement of that particular fellowship or that requirement of that particular consultant, and pitch your CV according to that. So just don't have one CV and keep on blasting it at all the places. So keep space for adjustments in your CV, ramp it up, or tone it down as per the requirement of that particular job.
Amit, you want to sum up everything, or just I think everyone has done a great job just summarizing each and every point. I just went through the efforts of writing each
Any
and every
missing
point.
point
I
from the
think
chat box?
We've covered most of the
we've
chat box.
covered
Yeah.
all of the chat box,
Yeah.
and also everyone has very nicely summed up everything.
Yeah.
So the work-life balance is what we started on. Then we ended up on the same fact that you should realize what you're going for, and you should realize at what point you're going, and the clear concept of what you want to attain from the foreign land which you want to go at, whether you want to get your skills improved and come back, or you want to stay back there, should be clear in your head before you embark upon this journey. So Gauri, do you want to quickly finish it off, since we have already gone through all the chat box questions? I think we are good to.
Thank you, Harshal, Amit,
Thank you.
for excellent session, Ashish, Rohan, and Mathu sir. Thank you, everyone. Yeah.
Thank you.
Thank you so much.
Thank you very much, everyone.
Thank you.
Thank you.